an aged male, approximately a 60 years male, is going to present, okay, with signs symptoms of anemia, like fatigue might be there, okay. All these signs symptoms will be there, and this is how they might present. So in the blood, can you appreciate these cells? What are these cells? Yes, can anyone tell me what are these cells? Huh? These are
Lymphoblasts.
not lymphoblast. I am telling you,
Lymphocytes.
these are
Small
mature,
lymphocytes.
small lymphocytes. These are mature lymphocytes. Already we have read the tumor is not arising from a precursor cell. It is not a blast. And blast, they are much more larger as compared to the size of RBC. So if you see the nucleus and if you see the size, it is absolutely the small lymphocytes. But one important feature of this lymphocyte is that they are monoclonal in nature. Okay, they have certain genetic alterations which are common in all the cells. For example, loss of 13p that we have already seen, or maybe Notch1 mutation is present. Okay. Now, can you appreciate that in the background, we are having certain things like this? What are this? What is this called?
Smart cells. Smart cells.
Can you tell me why smudge cells are formed?
Smearing artifact.
Yes, it is a smearing artifact. What happens over here in the smudge cells, that these cells, okay, these cells, that is these cells are basically, if you see that these cells are what should I say, these cells are basically very fragile. Okay, these are very fragile cells, and when they are smearing, so in a slide, when you smear it, okay, when you smear them, and then when the smearing is done, it actually crushes your lymphocytes. Okay, so as a result, because it is crushing the lymphocytes, they appear as a smudged cell, also called as basket cell. Is it clear to everyone? Okay. And this is the part which is having the small lymphocytes, small mature lymphocytes. Okay. And this is the area which is the proliferation center, which is seen. And this is the area of active proliferation of the cells. Now, if you see over here, some small lymphocytes or some small lymphocytes, mature lymphocytes can be seen. But majorly, you are having some cells which are having a clear cytoplasm and a very prominent central nucleus. Yes or no? Can you appreciate? These cells are actually the pro-lymphocyte. These are called as the pro-lymphocytes, which forms the major amount of the proliferation center. Okay. So this upper left field, as is shown, it is basically called as a proliferation center, which is composed mainly of pro-lymphocyte, which is having a clear cytoplasm, and it is containing very prominent nucleus. And actually, these basically constitute the proliferation centers, which are the diagnostic hallmarks of SLL. Okay, is it clear to everyone? What is proliferation center and what are the main components? What are pro-lymphocytes and what are the major cells? They are small mature lymphocytes. We are going to start with the peripheral B cell or mature B cell neoplasm. The first most important neoplasm is your chronic lymphocytic leukemia or small lymphocytic lymphoma. So what very important thing is, if I am saying leukemia, what does it mean? It is involving the peripheral blood. And if I am saying lymphoma, the same lesion is involving a lymph node. Okay. So that is the basic difference between lymphoma and leukemia. I hope you all understand. So chronic lymphocytic leukemia and small lymphocytic lymphoma, they differ only in the degree of peripheral blood lymphocytosis. In CLL, the peripheral blood lymphocytosis is there. In SLL, you will see the lesion confined to the lymph node. Now, there are different diagnostic requirements and there are different entities under the discussion of CLL, SLL. So the diagnostic requirement for CLL, what is it? That is the absolute lymphocyte count should be more than 5,000 per cubic millimeter in the peripheral blood for at least 3 months. And this absolute lymphocyte count that is increased, these are monoclonal lymphocyte. Means all of them, they have certain aberrations, some molecular alterations which are similar in all the cells. So they are monoclonal. Okay. So the absolute lymphocyte count should be more than 5,000 for a duration of at least 3 months. Lymphocytes, they should be small, mature looking with high NC ratio, round to oval nucleus and clump chromatin. This is very similar to a normal small lymphocyte. Normal small lymphocyte. Okay. One very important characteristic feature of such cells is that these cells are easily crushed, giving rise to what is called as smudge cells or basket cells. I am going to show you all these things later on when we discuss morphology. Now, characteristic IPT should be there. That is going to demonstrate the monoclonality. And pro-lymphocytes are basically those lymphocytes which are having prominent nucleolus. They are slightly larger than the normal lymphocytes. Okay, I will show you what pro-lymphocytes are. The level of pro-lymphocytes should be less than equal to 55%. That is the requirement for the diagnosis of CLL. Coming to the diagnostic requirement of SLL, okay, it should be predominantly extramedullary. As I told you, just there should be lymph node involvement. Okay, so in the lymph node should show a diffuse proliferation of small lymphocytes with scattered proliferation centers. What are proliferation centers? We are going to discuss later. And the amount of monoclonal B lymphocytes in the blood should be less than 5,000. That is a requirement for the diagnosis of SLL. Okay, remember both CLL or SLL, they are same, just that the site of involvement is different. There is a very important entity called as monoclonal B lymphocytosis called as MBL. Here, the absolute monoclonal B lymphocyte count is less than 5,000 with IPT, okay, of the CLL. Okay, it is showing all the molecular alterations of CLL. Okay, so they are monoclonal lesions, but they do not present any signs, symptoms, or cytopenias. So it is considered as a precursor of CLL with a rate of progression of MBL to CLL being 1 to 2% every year. So remember one thing, very important is not only the count should be more than 5,000 for the diagnosis of CLL, but also IPT should demonstrate monoclonality. Okay, but if the monoclonality is there and this feature is not fulfilled, then we are using the term monoclonal B lymphocytosis. Always remember this thing. It is a precursor of CLL. Remember, CLL is the most common leukemia of adults in the Western world, while it's the least common type in a country like India. So remember, in India, okay, the most common, leukemia is CML, accounting for 40%. Then comes ALL, accounting for 35%. Then comes AML, accounting for 15%. And then comes CLL, that is the least common leukemia in our country. So most common is CML, least common is CLL. Okay. Okay. Moving ahead, one very important thing is the history of the patient. Such individuals are presenting at an age of around 60 years, and there is a male predominance. Excuse me. In contrast, the SLL constitutes only 4% of non-Hodgkin's lymphoma. So basically, CLL is a far more common presentation of this disorder as compared to SL. Okay. Now comes the most boring part that you all do not like, but unfortunately you have to remember this part. The most common chromosomal translocations seen are those which involves chromosome 13q, 11q, and 17p. So there are deletions of these particular chromosomes, including there is trisomy involving 12q. Now, the deletions involving 13q is implicating two microRNAs, that is microRNA 15 and microRNA 16. Okay. Now, loss of these microRNAs leads to overexpression of a anti-apoptotic protein, that is BCL2. So always remember, if the amount of BCL2 increases, what is going to happen? That is, it is going to, because BCL2 is what? It is anti-apoptotic. It doesn't allow apoptosis to occur. So it ensures the survival of these tumor cells. So more BCL2 release, more is the survival. And why BCL2 has increased? Because of decreased expression of microRNAs 15 and 16. And why that was there? Because of deletion of 13q. Okay. Not only that, as I am telling you, as I told you, let me show you one important thing. Over here, just remember one thing, that the origin of CLL is twofold. Okay. Now, naive B cell. What is the meaning of naive B cell? Naive B cell is a virgin B cell. Why I am calling it as a virgin B cell? It is a virgin B cell because it has never encountered any kind of antigen. So it is naive. We call it as naive. It is a virgin B cell. So one origin of the CLL, SLL can take place from the naive B cell. Whereas another group of CLL, they are arising from those B cells which have undergone, somatic hypermutation. That means they have entered the lymph node and they have entered the germinal center. Now, which B cells enter the germinal center? Those that are exposed to some kind of microbial agent or any stimulus that are stimulated, that have encountered an antigen. So the second origin of this is your post germinal center or from the germinal center. Okay, so remember, these are the two important source of origin of CLL, SLL. Now, why am I telling you this? Because this has prognostic implications. Okay, so those that are arising from the post-germinal center B cell, okay, they have an abnormality, okay, which is involving, which is actually they are said to be somatically hypermutated. What do you mean by somatically hypermutated? Those particular B cells which have encountered an antigen and now they are proliferating. They are proliferating. That means antigen specific lymphocytes are proliferating. They are actually said to be somatically hypermutated. Okay. Okay. So basically, the origin of these cells is either from the post-germinal center or from the naive B cell. Always remember why it is important that tumors which are arising from the unmutated segments, that is from the naive B cells, they pursue a more aggressive course. Always remember this point. Very important prognostic feature. Okay. Another mutation is gain of function mutation involving Notch1 receptor seen in 10 to 18% of the tumors. Okay. The growth of CLL, SLL is largely confined to proliferation centers. Now, what are proliferation centers? I'm going to show you. Okay, that is classically seen in case of CLL, SLL. And as I told you, even in case of Hodgkin's lymphoma, the transcription factors in most hematological neoplasm is NF-kappa beta, which is driving the growth and survival of the B cells. Along with that, the MYC transcription factor also promotes growth. And the NF-kappa beta ensures the cell survival. Okay. Now, other important thing is that over here, there is a particular pathway called as a signaling pathway that includes BTK, that is Bruton tyrosine kinase, which is also, helping in the growth and survival. Remember, the CLL cells, they depend on this B cell receptor signaling and the BTK activity for their growth and survival. So this is basically an enzyme. Okay. This is basically an enzyme on which the survival depends. And these are transcription factors which is ensuring survival. Okay. Okay, so any doubts over here, excuse me, with regards to genetic alterations? Yes. Okay, so the role of deletions, trisomy, microRNAs, what is somatic hypermutation, origin from post-germinal center, naive B cell, which origin is more aggressive? You should remember what is Notch1 mutation, what are proliferation centers, and in the proliferation centers, which transcription factors are ensuring the growth and which enzymes are ensuring the growth. This should be very clear. Now, coming to the morphology. Okay, so before I go there, this is basically one important morphology. Now, what is this? What is this? This is a lymph node. Does a normal lymph node looks like this?
No, sir.
A normal. So a normal lymph node is looking like this. I'm just showing you a normal lymph node so that you can understand. Okay. So normally the follicles, they are limited to the cortex. Okay. They are limited to the cortex. And these follicles, okay, these are said to be secondary follicles. Why am I calling it as secondary follicles? Because they have been stimulated. This is the germinal center. And over here in the periphery that you can see, they are the mantle zone and the marginal zone. Okay, on the outer aspect. In the medulla, you see certain dilated sinus channels called as medullary sinus. And these are the medullary cords. So over here, basically the sinus histiocytes are basically predominant in the sinuses. Okay, is it clear? This is the normal arrangement. So normally in the periphery, you are going to see the lymphoid follicles. Okay, and the center you see this medullary sinuses. Okay, now can that be appreciated over here? So remember, in any kind of malignancy arising from the lymph node or even metastasis, this particular normal lymph node architecture is completely gone. And this architecture, when it is gone, we use the term effacement. We use the term effacement. So it is imperative that you understand and use the term effacement. So first of all, like in any other kind of lymphoma, over here also there is a diffuse effacement of the nodal architecture that you can appreciate. Coming to the next important picture, what kind of cells are infiltrating? So these are majorly, these are small mature lymphocytes like cells. Small mature lymphocyte like cells. Now, can you appreciate there are certain areas which are more clear as compared to other areas? There are certain areas which are more clear. Is that appreciable to everyone? They look like pale areas. They are looking like washed out areas. Is it appreciable to everyone? Certain areas are very pale. Why is it pale? Do you know? This area is the area showing active proliferation, and this is called as proliferation centers, which are classically seen in case of SLL, CLL. Now, can anyone tell me, right now we had discussed about two transcription factors which are driving the proliferation. Yes. What are those? One is NF, kappa beta, another one is your MYC. These are the two transcription factors which are driving the mutation. So here, this proliferation center that you appreciate in the low power view, this is the most important finding in the case of a SLL or CLL. Okay. So in between, there is a increased amount of small mature dark staining lymphocytes. Okay. So once you go inside the proliferation center, you are going to see, this is the proliferation center, if you can appreciate. Okay. And this is the part which is having the small lymphocytes, small mature lymphocytes. Okay. And this is the area which is the proliferation center which is seen. And this is the area of active proliferation of the cells. Now, if you see over here, some small lymphocytes or some small lymphocytes, mature lymphocytes can be seen. But majorly, you are having some cells which are having a clear cytoplasm and a very prominent central nucleus. Yes or no? Can you appreciate? These cells are actually the pro-lymphocyte. These are called as the pro-lymphocytes, which forms the major amount of the proliferation center. Okay. So this upper left field, as is shown, it is basically called as a proliferation center, which is composed mainly of pro-lymphocytes, which is having a clear cytoplasm, and it is containing very prominent nucleus. And actually, these basically constitute the proliferation centers, which are the diagnostic hallmarks of SLL. Okay. Is it clear to everyone? What is proliferation center and what are the main components? What are pro-lymphocytes and what are the major cells? They are small mature lymphocytes. Okay. So if you read over here, lymph nodes, the firstly very important term, they are diffusely effaced. Predominantly, what is the cell? Small lymphocytes. Okay. And these cells, they are small, round to slightly irregular nucleus with a condensed coarse chromatin with a scant amount of cytoplasm. Admixed with them, they are large activated lymphocytes, okay, which is basically aggregating to form what is called as a proliferation center, which basically contains mitotically active proliferating cells. Okay, when present, the proliferation centers, they are pathognomonic for CLL, SLL. Very important MCQ. Okay, now this is all about what is present in the lymph node. Okay, let us see what happens when they involve the blood. So can you appreciate these cells? So basically, an aged male, approximately a 60 years male, is going to present, okay, with signs symptoms of anemia, like fatigue might be there. Okay, all these signs symptoms will be there, and this is how they might present. So in the blood, can you appreciate these cells? What are these cells? Yes, can anyone tell me what are these cells? Huh? These
Lymphoblasts.
not lymphoblast. I am telling you,
Lymphocytes.
these are
Small lymphocytes.
small lymphocytes. These are mature lymphocytes. Already we have read the tumor is not arising from a precursor cell. It is not a blast. And blast, they are much more larger as compared to the size of RBC. So if you see the nucleus and if you see the size, it is absolutely the small lymphocytes. But one important feature of this lymphocyte is that they are monoclonal in nature. Okay, they have certain genetic alterations which are common in all the cells. For example, loss of 13p that we have already seen, or maybe Notch1 mutation is present. Okay. Now, can you appreciate that in the background, we are having certain things like this? What are this? What is this?
Smart
called?
cells. Smart cells.
Can you tell me why smudge cells are formed?
Smearing artifact.
Yes, it is a smearing artifact. What happens over here in the smudge cells, that these cells, okay, these cells are basically, if you see that these cells are what should I say, these cells are basically very fragile. Okay, these are very fragile cells, and when they are smearing, so in a slide, when you smear it, okay, when you smear them, and then when the smearing is done, it actually crushes your lymphocytes. Okay, so as a result, because it is crushing the lymphocytes, they appear as a smudged cell, also called as basket cell. Is it clear to everyone? Okay. Now, can anyone tell me what other abnormality is seen in this particular slide? Can anyone just highlight the other abnormality seen in this particular slide? Yes.
RBC.
Yes, there is a presence of nucleated RBC. Now, why am I telling it as it is a nucleated RBC? Why it is not a lymphocyte and why it is an RBC? Can you appreciate the nucleus of an NRBC is pycnotic in nature, means it is dark condensed. Okay, it is dark condensed, that is pycnotic. And again, look at the size of the NRBC. It is much smaller than the small lymphocyte and it is quite dark. That is how you identify the NRBCs. Now, what is this NRBC indicating? The presence of NRBC is indicating what? What is the indication of
Presence of spirocytes.
No, NRBC presence is not indicating spirocytes.
Erythropoiesis.
Yes, the presence of NRBC is indicating that there is an accelerated erythropoiesis that is going, means there is some hemolytic picture which is going on, because of which the NRBCs are coming in the circulation. So there is an accelerated erythropoiesis that is taking place. That is what is the basic signal over here. There is an accelerated erythropoiesis that is taking place. Okay, just remember this thing very importantly. So this accelerated erythropoiesis is telling us that some kind of hemolytic anemia is taking place. Something like this is taking place. Okay, so remember, around 20% or very few cases of CLL SLL also have associated autoimmune hemolytic anemia. Autoimmune hemolytic anemia is there, that is called as AIHA. Okay, and classically, if you see what is the feature in this particular peripheral blood smear that is indicating autoimmune hemolytic anemia, can anyone tell me? Yes, see, this is the normal RBC. Look at this RBC. Look at this RBC. Look at this RBC. Is it normal? Are these RBCs normal? What are these? Yes, these are spirocytes. These are spirocytes. So the typical feature of a spirocyte is that, excuse me, that they are smaller than the normal RBC. The central pallor which is present in the normal RBC is not seen over here. Okay, and they have a condensed cytoplasm, and the concentration of hemoglobin is very high because the space is less, so it is condensed. So that is the feature of a spirocyte, and they are completely round, they are not biconcave. That is the feature of spirocytes. So around 20% of the cases might contain spirocytes indicative of autoimmune hemolytic anemia. So this is the classical picture. So always in the clinical history, whenever you see a clinical history in your exam, you should always see whether the peripheral blood smear is showing features, whether the hemoglobin is decreased. For example, the hemoglobin is around 8 gram per deciliter. Okay, whether the hemoglobin is decreased, that is indicating some sort of hemolysis is going. Whether any findings of NRBCs are mentioned, whether any findings. So in that case, you have to elaborate on the features of spirocytosis also. Okay, so coexistent autoimmune hemolytic anemia and spirocytes, okay, they are very, very important feature that can give you a hint to the diagnosis of this disease. So in the exam problem cards can be used, and this particular picture might also be given in the competitive exams. Okay, is it clear how it is involving the blood? Yes, everyone? Okay. So the blood, when we are looking at the peripheral blood smear, that means we are speaking about CLL. In that case, we see the small, round, mature lymphocytes with scant cytoplasm. Okay, and they also contain the smudge cells. Always remember this thing. Now, in most cases, the bone marrow, spleen, and liver, all of them might be involved. So hepatosplenomegaly might occur in this case as well. Okay. Okay. So very, very important thing is the immunohistochemistry. As the topic of discussion today is mature B cell neoplasm. So the B cell marker will be positive. So the markers like CD19, 20, 79A, PAX5, all these will come out to be positive. What is very important is the two important markers, that is CD23 and CD5. They are usually positive over here. They are present. Now you will ask me, sir, CD5, though it is a marker of T cell. Then how you are saying that is a B cell neoplasm? Now this CD5 expression, it is aberrant. It is aberrant. It is not correct expression. That is why we are, it is a neoplasm. It is aberrant expression of CD5. Okay. So remember, CD5 expression along with CD23 expression is classical of CLL SLL. Now remember, these tumors are not very, highly proliferating tumors. So the Ki67 index is usually low. And one other thing is that, they have a decreased expression of surface immunoglobulin. So all B cells, they have a they express all the B cell receptors. They are nothing but IgM or IgD. Okay, so this expression is seen in all the B cells, but over here the expression of surface immunoglobulins are decreased. Okay, and also they have increased expression of BCL2, especially in the proliferation center. Is it clear the immunohistochemistry of SLL, CLL? Excuse me. Now comes the bone marrow biopsy. Okay, what is the important? First of all, you have to understand bone marrow involvement or bone marrow biopsy or bone marrow aspiration or biopsy. It is not essential for the diagnosis of CLL. For CLL, it is not essential for diagnosis. I'm using the term diagnosis. But for prognosis, it is helpful. What is the importance of prognosis? So, for example, you have done a bone marrow biopsy. So, normally you see that here you have the bone marrow substance, and this is your paratrabeculae, the bone. This is the trabeculae, the bone, the bony trabeculae. Okay. Sometimes the involvement is interstitial type. That is, you have scattered small lymphocytes. Sometimes the involvement is nodular. Okay. The lymphocytic cells or the tumor is formed in the presence of nodules. Sometimes there is a diffuse involvement. Sometimes you might have a mixed nodular plus interstitial. So interstitial variety is having the best prognosis, whereas if you see the nodular variety is having less than best, and the diffuse is having the worst prognosis. So basically, just for prognostic purpose, the bone marrow examination can be done, but it is never indicated for diagnosis. Diagnosis can be made looking at the smear and also by doing the immunophenotyping. Okay. Okay. So this is the immunohistochemistry, as I am showing you how the presence of CD20 is seen, that it is indicating it is a B cell neoplasm. Now CD5 positivity and CD23 positivity, both of them are positive. They are showing cytoplasmic positivity over here. Okay, so very important is this. This is indicative. This is the characteristic immunophenotype profile, IPT, the IHC profile of CLL, SLL. Okay, so clinically, patients are asymptomatic at diagnosis. So like any lymphoma, remember, non-specific sign symptoms, according, for example, the patient develop anemia or cytopenia. So easy fatigability, weight loss, anorexia can be there. Now, in the course of time, generalized lymphadenopathy with hepatosplenomegaly will be present in 50 to 60% of the patients. Okay, remember, the counts are not very high. Usually the counts look like the normal count only. Okay, or maybe around 30,000, 40,000, it might be. Sometimes leukopenia might be there, sometimes the count can vary. So count is quite variable and it is not a deciding factor. Now, CLL is also disrupting the normal immune function. So usually there is hypogammaglobulinemia, and such patients are quite susceptible to infection. Now remember, only 10 to 15% of the patients develop what is called as hemolytic anemia, which is autoimmune hemolytic anemia, or they might have thrombocytopenia because of formation of autoantibodies, okay, formed by the non-neoplastic B cells, which are acting against the platelets and RBCs. And remember, although this is taking place in 10 to 15% cases of CLL, remember, in your exam question, 100% of your exam question will give this history. So that is why this becomes important. Now, the median survival is around 4 to 6 years. It is sometimes it might cross more than 10 years. So basically, the prognosis is not very bad. It is good. One very important thing is that sometimes this CLL, SLL, they might transform to a high-grade lymphoma like DLBCL. And in that case, we call this transformation as Richter syndrome, seen in approximately 5 to 10% of the patients. Okay. Some other mutation which is having a very bad prognosis is the presence of TP53 or MYC mutation. Such patients having such mutations have a survival of less than 1 year. Now, this is a part. This is showing what is called as a Richter's transformation. Now, if you see over here in this part, okay, this is a case classical of SLL. Okay, whereas if you see over here, the cell has transformed to large B cell lymphoma. Can you see? This is the characteristic DLBCL that has developed. This is called as a Richter's transformation. Now, the prognosis, very important exam question. As a part of your problem card, this will be asked in your exam also. What are the prognostic factors? So remember, the presence of deletions 11q and 17p, okay, a lack of somatic hypermutation, that is tumors which are arising from naive B cell, okay, and also the presence of CD38 positivity and ZAP70 positivity. The overexpression of ZAP protein, the presence of Notch mutation, Richter transformation, diffuse pattern of bone marrow involvement, male gender, old age, advanced stage disease, like you can just leave out this, the staging part, more than 10% pro-lymphocytes. All these features, presence of all these features are indicating a bad prognosis. Bad prognosis. At least if you remember 5-6 of these causes, you are done. Means this is correct. So what are the things that you cannot, forget to, leave out? So lack of somatic hypermutation is the most important factor indicating the prognosis. So lack of somatic hypermutation, which is indicating an origin from the naive B cells, is indicating bad prognosis. Expression of ZAP70, Richter's transformation, diffuse pattern of bone marrow involvement, okay, more than 10% pro-lymphocytes, male gender, these are very important prognostic factors to be reckoned with. Now, any doubt you have? Now, as I told you in the diagnosis of CLL, SLL, the amount of pro-lymphocyte should be less than equal to 55%. Yes or no? I told you, if it becomes more than 55%, the condition is called as B pro-lymphocytic leukemia. Okay, it is having a more aggressive disorder, and the amount of pro-lymphocytes will be higher over here. Okay, just remember this thing.